I am Eliseo Perez Estable. I'm the director of the National Institute on Minority Health and Health Disparities. And I would like to welcome you to the NIMHD Director Seminar Series, which today highlights Dr. Chau Trinh-Shevrin from New York University. Our series highlights prominent researchers who are working in the science of minority health and health disparities. And after an initial pause last year when the pandemic shut us all to work at home, we have reassumed our pace with virtual presentations. So today we're really honored to have Dr. Trinh-Shevrin. Chau is a native of Vietnam who came to the US as a refugee from the Vietnam War, or as the Vietnamese called it, the American War. She went to State University of New York, where she got her BA in English and then master's in health policy before going to Columbia University for her doctorate degree in public health. Shortly thereafter, she joined New York University as an assistant professor in 2005 and was promoted to full professor in 2020. I first met Chau because she was on the committee, the search committee that found me to be the director of NIMHD, and subsequently got to know her work, and also as a principal investigator for many years of an NIMHD-funded Center of Excellence. Over these past 20 plus years, her research has really been centered on rigorous development and evaluation of multi-level strategies to reduce health disparities and advance health equity, with a special focus on Asian Americans. She's a PI on a number of grants for NIH. I will make note of the NIMHD Center of Excellence for study of Asian American health, which was renewed in the call that we made after I arrived as director, even though we reduced the number significantly. She also has a National Institute on Aging K07 award, an R24 award on engagement and longevity and medicine research collaborative, and just about everyone doing diversity work or health equity work in the area that can get her as a co-investigator has. She mentioned earlier in a conversation with her about the role in the SEAL project that we just approved in the New York area, of which she's also involved. Chau has used the expertise in community engaged research using longstanding relationships with local, regional, and national partners. She co-directs the Community Engagement and Population Health Research Corps for New York University Health and Hospitals and their CTSI. She's also been active in the community, being board of directors, Chinatown YMCA of New York City, and New York State Department of Health's Medicaid redesign team, working on health disparities work group and delivery system. She's authored or co-authored more than 100 peer-reviewed papers, is co-editor of 2 textbooks, and just a remarkably nice person. So today her talk is entitled Achieving Health Equity for Asian Americans, Research, Policy, and Action. A very timely topic in the context of what NIH is going through in the UNITE process. So Chau, we look forward to your talk.
Thank you so much, Elsa. I really appreciate this wonderful introduction. Good afternoon, everyone. I'm really delighted to be here today. My presentation is focused on achieving health equity for Asian American communities, the research, policy, and action. I have 4 objectives: to understand drivers of health and health disparities for the Asian American population, to describe multi-level strategies to reduce health disparities, describe the impact of the COVID-19 pandemic on the health of Asian Americans, and also discuss recommendations to advance health equity for Asian American communities. Next, please. I'm going to begin with some context very briefly about the Asian American population. Next. Asian Americans are the fastest growing population. We're expected to grow to about 39 million by 2060, representing nearly 10% of the US population. And in New York City, we already represent nearly 15% of the city's population, and we're growing in size. This is in part fueled by immigration trends. Next, please. To give you a sense, there has been a 34% population growth among Asian Americans compared to 22% for Native Hawaiian and Pacific Islanders and 6% for other Asian American communities. Next, please. We fall under three broad subgroups: East, Southeast, and South Asians. And as you can see, there's tremendous diversity within these subgroups with respect to country of origin, cultures, and language. And we also differ in population size and diversity. Next, please. We are geographically dispersed. More than half of Asian Americans live in 5 states: California, New York, Texas, New Jersey, and Washington. And New York City has the largest concentration of Asian Americans. We have more than 1.3 million Asian Americans in one city. And we're representative of the diversity of the Asian American population, including many South, Southeast, and East Asian communities. And we also have a very large first and second generation immigrant population. My presentation today is going to really focus on the Asian American population, given the breadth and depth of my work in this area, focus in New York City, and also out of deference and solidarity to my Native Hawaiian and Pacific Islander colleagues and community partners. So I'll try to separate the work that we do in the Asian American population from these other communities. Next, please. By nativity, Asian Americans have the highest proportion of foreign born. More than half are first generation compared to the US population. Next. But if you look at the data disaggregated, broken down by subgroups, you also see that nativity varies by Asian ethnicity, with the Japanese low as 27% and a high of 85% for the Bhutanese community. And this has implications for access to community resources and risk for disparities. Next. Now, if you aggregate Asian Americans, you also see a higher educational attainment level compared to the rest of the United States, based on the measure of share bachelor's degree by ages 25 and older. If you look at the data in the aggregate, you'll see a much higher proportion, 30% versus 20%. Next. But when you look at the data disaggregated, you see profound differences across Asian ethnic groups. You also see that there are many subgroups who have much lower rates of educational attainment compared to all Americans. Next, please. Income also tells a similar story. Asians in the aggregate do much better than all other US communities. Next. But there are stark differences when you disaggregate by Asian subgroups, with many who earn much lower than the average American income. Next. In New York City, for example, Asian Americans actually have among the highest poverty levels compared to other racial and ethnic groups. But oftentimes this data is not presented or dismissed or excluded in terms of thinking about social and economic disadvantage for Asian American communities. Next. Language barriers also persist. English proficiency rates are lower for all Asian subgroups compared to other racial and ethnic groups. And you can see by the slide that these rates differ across Asian subgroups. Next. I'm going to switch gears for a moment, and I'm going to highlight a few of the major health disparities: diabetes, hypertension, and cancer, but really mainly to underscore the salience of disaggregated data collection and analysis. Here, data from the New York City Health Department that should illustrate that diabetes disparities persist for all racial and ethnic minority communities and are pronounced for Asian subgroups, particularly South and Southeast Asians. Next. And when we look at the data with respect to diabetes prevalence by Asian American subgroups across different data sets, across different regions, and for different Asian subgroups, we still see striking diabetes disparities that exist. Next. Asians also have a higher diabetes risk at lower BMI levels compared to other racial and ethnic groups. So the World Health Organization and the American Diabetes Association have also called for using lower BMI cutoffs to assess diabetes risk for Asian American communities, of really centering and understanding risk based on that community as opposed to a different standard. Next, please. In New York City, hypertension disparities are also evident for all racial and ethnic minority communities. They also differ for Asian subgroups, with South and Southeast Asians having higher rates compared to other Asian subgroups. And then if you look at the South Asian rate, for example, you see that it's at 43%, which closely approaches that of Black and African Americans at 43.5%. So high hypertension disparities among this population. Next. There's also a substantial cancer burden for Asian American communities, and the leading cancers also differ across Asian subgroups from country of origin, culture, language access, religious affiliation. All of these factors impact cancer rates and also cancer risk factors, which has implications in terms of thinking about targeted prevention and intervention strategies. Unfortunately, there is very little data around how best to tailor. More data has been probably available for addressing cancers for Asian Americans, but even that, thinking through tailored strategies to reduce the cancer burden and cancer disparities are in some ways are very limited. Next, please. We also know that cancer screening rates are generally lower for Asian American groups compared to others. And we also realize that the uptake of evidence-based prevention strategies for infection-related cancers, which have a high, which represents a high burden for many Asian American communities, is very limited in terms of reach and not fully optimized. So, for example, hepatitis B screening is something that can be done to reduce liver cancer disparities, and liver cancer disparities are particularly pronounced for East Asian subgroups. And we also know that many preventable cancers, such as lung, stomach, liver, and colorectal, top many of the cancer disparities across Asian American subgroups. Next, please. So overall, cancer, heart disease, and diabetes, as well as stroke, remain leading causes of mortality, yet they differ if you look at the different subgroups with respect to those leading causes. We are also seeing an emerging risk that's rapidly increasing for all Americans as well as Asian subgroups, and that's Alzheimer's disease. That's a major concern given the need to understand how best to tailor prevention and intervention strategies for different communities. And that's an area that we hope to be able to grow our focus on in the next few years. Next. So I'm going to briefly touch on issues of drivers of disparities. Next, please. I want to talk about structural racism, the stereotypes of the model minority, perpetual foreigner, carriers of disease, as well as the intersectionality that occurs when you occupy both a racial minority group and also, also are an immigrant or a second-generation immigrant, and what that might imply with respect to stereotypes, racism, and discrimination. I also want to touch on the issue of data inequities, specifically the lack of data disaggregated by subgroup that's available, and the need for more funding for not only intervention studies on different health issues, health disparity issues that occur among Asian Americans, but also the need for more cohort, observational, longitudinal studies on this population and disaggregated by the various Asian American subgroups. I also want to touch on the limited access to social and health resources and how that may impact health disparities, as well as the barriers due to language access and limited English proficiency. Next. This figure here was developed by our colleagues Gilbert G. and Annie Rowe, who wrote a chapter in our textbook that was published in 2009 on Asian American communities and health. And they talk about racism through the image of an iceberg. And when you think about interpersonal and overt racism, which is what we tend to think about when we see racism, and that refers to explicit racism, that refers to discrimination and microaggressions, that represents the tip of the iceberg. What exists below the surface is often foundational, and that's structural or systemic racism that is embedded, normalized within every US institution, and has led in many ways to unequal access to quality education, to living wages, to access to care, and access to other resources. Next. And then I'm going to talk about health equity for a moment. So health equity has been defined in some ways as the highest attainment of health. And there are various depictions of equality and equity. So if you look at the figure at the top left, this one illustrates that limitations and disparities are not individual level characteristics, but instead are inherent to the system or the track. So in the top equality figure, everyone starts the race off at the same level, but there are tangible advantages to being the blue runner. It represents the shortest distance compared to other lanes. Some groups start off the race with a clear advantage and remain that way throughout the race. Now, if you look at the bottom left figure, you also see that if you want to achieve equity, you have to adjust the starting points for each of the lanes. In the last 15 months, it's really become apparent that systemic racism is a fundamental and structural determinant of health. And it really begs the question of whether the way we're thinking about equity is enough. We actually need to begin to understand and systematically dismantle the structures by which power is conferred and for which those who are disempowered remain powerless, and really move towards a justice perspective of dismantling the roots of racism if we ever want to achieve health equity. Next, please. The Black Lives Matter movement underscored this point. And then the violence of the last 15 minutes towards Asian Americans, and particularly in the last few months, have also made this point salient of thinking about structural racism and its impact on health disparities, and how it's systematically rooted in our systems. Next, please. Historically, Asian Americans have a long history of experiencing structural racism and discrimination, rooted in anti-Asian immigrant laws. The 1882 Chinese Exclusion Act was the first piece of US legislation that barred a specific ethnic group from immigration and from naturalization. And this cartoon from September of 1879 depicts the racialized position of both Blacks and Chinese in this period. This didn't change markedly until 1965, when the quotas for immigrants were increased for all countries outside of the US. And so it essentially that increased the number of Asian immigrants that came into the country. It also had selective preference for families and selective preferences for professional level immigrants. This last preference of highly skilled, highly professional level immigrants helped to undergird this notion of the model minority stereotype. Next, please. So the model minority stereotype paints Asian Americans as a monolithic community, and it's characterized by positive traits of high educational attainment, high median family income, low crime rates, lack of juvenile delinquency, lack of mental illness, close family ties, law-abiding, hard work ethic, and that these individuals have overcome all barriers and have succeeded professionally and economically. And in many ways, it seems like a very positive stereotype. Next, please. It's also, this stereotype is also a hardy one. It began in the 1960s and it persists today. And it has helped to render Asian Americans as invisible. So what does it mean to be a model minority? Because we're invisible in many circumstances because we're doing what we're supposed to be doing, until we become hyper visible, like at the cover of this Time magazine, of doing what we do too well. Next, please. But the stereotype of the model minority was actually developed and rooted in anti-Blackness. And it was developed at a time by a conservative majority to oppose the Black Power movement of the 1960s. That movement highlighted the existence of institutional racism and that policies were structured to keep minorities in a subordinate position. The concept of the model minority became a strategy then to deny the existence of institutionalized racial inequalities. Asian Americans were the communities, the minority communities that were doing so well. And as mentioned, the immigration policies at the time were allowing very highly skilled Asian immigrants to come into the country. So they were the notable examples of high education and professional success as the hardworking individuals. And so the idea of Asians also as being all one big population and the notion of the model minority just took hold and persisted to this day. And so this concept of the model minority also switched focus to individual and community responsibility. Individual underperformance was the reason for racial inequality. If Black communities, for example, just worked harder, they too would move up the social ladder. And so essentially the success of Asian Americans at that time was utilized as a tool against the against the movement of ensuring that to really deny that existence of institutional racism. It also became a very cunning strategy to withhold resources to Asian American communities as they were already doing so well. This model minority stereotype was intractable to change. It's often internalized by Asian American communities and also by mainstream America. And so to the point that we see images of crazy rich Asians and other stereotypes becoming glorified, yet we know that there is a binomial socioeconomic distribution. We see that within and across Asian subgroups. We see that, for example, even within the Chinese community, there are the highest income earners, and yet they also have the highest proportion of individuals living in poverty. That same story can also be told for the South Asian population. And what it also does in a very insidious way is that the model minority stereotype, for those who fail to reach that ideal, there's an internalized stigma and frustration that occurs. Next, please. Alongside the model minority stereotype is this notion of a perpetual foreigner. So a historical example is, of course, the internment of Japanese Americans during World War II. And this top photo is that of a Japanese-owned Wanto grocery store in Oakland, taken 1 month after the executive order. And the owner has to assert him or herself that they are also an American. Recent examples of the perpetual foreigner include the COVID-related anti-Asian racism and the xenophobia that we are seeing since the pandemic, and also continuing to see now. Next, please. In 1999, sociologist Claire Jean Kim created this figure to illustrate the politicized and racialized position that Asian Americans have been placed in. So this racial triangulation figure, this model illustrates how Asian and Black tensions and white privilege racial hierarchy are upheld. So on the y-axis, Asian Americans are labeled as being superior to Blacks, hence the model minority stereotype, but inferior to whites. And on the x-axis, Asian Americans are labeled as outsiders, the perpetual foreigner, in relation to whites and Blacks who are insiders. And that result of the competing narratives for Asian Americans have largely helped to support the omission of Asian Americans in social health and policy debates. We're often underrepresented or not represented at all in a number of debates and including the recent issues that have emerged with respect to addressing the impact of COVID-19. Next. It's so clear that fear fuels hate and racism. From a community perspective, it's been devastating to witness and experience the psychological trauma of xenophobia and racist attacks towards Asian Americans. And history has repeated itself from the Yellow Peril to the more recent Kung Flu and the Chinese virus. We know that more than 4,800 reports of anti-Asian hate incidents have occurred since March of 2020. And we also know that many of these incidents of anti-Asian violence are often not reported. So that number represents an underestimate. In New York City alone, the police department saw an 8-fold increase in hate crimes towards Asian Americans in 2020 compared to the prior year. Next. The intersectionality of occupying multiple marginalized social positions has deep implications on health equity. Through immigrant policies that are often uniquely racialized against non-white immigrant communities, racist policies can be reinforced and used as a means to restrict and to marginalize. We need to move away from this assessment of immigrant health from a number of years in the country, from looking at limited English proficiency, but also to think through how do we apply a structural racism lens to immigrant disparities and to understand how immigrant disparities occur and think through the multiple pathways that might be done, whether through formal channels, through immigration policy and citizenship status that curtails access to resources and political participation for immigrant communities of color, to that more informal racialization through disproportionate immigrant enforcement and criminalization of communities of color from immigrant populations, and then also think through the intersections of economic exploitation. For example, many recent immigrants are working in low-paying positions, are often in frontline positions, and have more issues with respect to not having health insurance access, not being able to have access to sick leave, a number of challenges with respect to economic exploitation. And yet they're also living in neighborhoods that may be historically disinvested. And so where shelter-in-place policies are also very challenging. Next. I want to switch gears to how the model of minority has played out in health and research. In 1985, Secretary of Health Margaret Heckler issued this groundbreaking report on minority health, and the report was significant in its impact in advancing awareness and attention to minority health. And so it was a report that helped in many ways to improve the health of communities of color. It also, unfortunately, contained limited information on Asian Americans and reported that in the aggregate, that the data on Asians was that we were healthier than all other groups. That directly aligned to the model minority stereotype and perceived societal biases, and has continued to shape the narrative and discussion on Asian American health and health disparities to this day. Next. We have seen this play out in the presentation of data in a number of peer-reviewed journals for many conditions and for health issues. This is just one example of where we know from our own work in helping to facilitate linkages to the health exchange that was brought upon by the Affordable Care Act, that there was a significant amount of data on Asian Americans that could have been included in this analysis. However, the authors chose not to present the data, and their response was that it was in line with much of the literature on health disparities. This is not an isolated example. Many authors often choose to not present the data on Asian Americans when that data is available. And so in some ways, health systems researchers may continue to systematically perpetuate stereotypes. And with, clearly without data presented, the visual is that there are no health disparities. And so a community without health disparities is also a community not in need of resources or attention. Next, please. This extends to what we see in COVID. During the spring and summer, the data that was presented by the CDC really shaped the narrative on COVID. The COVID-19 highlighted the deep structural inequities for racial and ethnic minority communities, which is so true, and also had a devastating toll on Black and Latinx community, also very true. Next. However, it was clear that there was evidence of a disproportionate burden on Asian Americans. Structural challenges and biases continue to leave out Asian Americans even when the data is available. So this first figure was released in mid-September 2020. And among patients who tested positive, Black, Hispanic, and Asian patients remained at higher risk of hospitalization and death compared to whites. However, the findings on Asian Americans did not receive much press. And it really runs counter to entrenched stereotypes of a model minority. It also ran counter to a narrative that was already established in April of 2020, focusing attention to other minority communities. My colleagues, Drs. Nadia Islam and Stella Yee, also observed similar findings in data in New York City, working with the New York City Health and Hospitals, which is, for many of you who may not know, the Health and Hospitals is the city's largest safety net provider and the country's largest municipal healthcare provider. They serve more than 1 million New York City residents, many of whom are on Medicaid, who are under or uninsured. And working with colleagues at Health and Hospitals, Nadia and Stella were able to apply innovative surname analysis to improve data quality and classification of Asian American communities. And with that, we were able to identify 10,000 Asian patients in their database, and allowed us to also disaggregate for South Asians and for the Chinese community. We also found higher infection and hospitalization rates among South Asians, second only to Hispanics, and second to Blacks for hospitalization. And we also found that Chinese patients had the highest mortality rate compared to all other groups. Yet despite the findings from CDC and data from California and New York City, next please, Asian Americans have largely been invisible during the pandemic in research. Next. And we've also been invisible during the pandemic in the media. Next, please. And this also came up with respect to research funding and vaccine allocation policies. The Eradic program is a tremendous program, really, focusing attention on underserved, high-risk populations, different communities of color, but it has unfortunately paid little attention with respect to outreach and engagement to Asian American communities. Even in their first and in their second press release, Asian Americans were not included as the communities, some of the communities that were being targeted by the Eradic initiative. Through a search on NIMHD Reporter, we were able to identify some of the studies that included Asian Americans, but not nearly representative of the diversity of Asian Americans, and none that were inclusive of South Asians, who we know had a really high disproportionate burden of COVID-19, as well as risk factors such as diabetes and hypertension that would put them at greater risk for COVID-19 related outcomes. In addition, the NASEM report with respect to vaccine allocation to vulnerable populations left out Asian Americans, as well as Native Hawaiian and Pacific Islanders in their first release of the draft framework. Working with our colleagues and community partners across the country, we presented data that we had from various sources around COVID-19 and its impact on our communities. And in the final report, we were glad to see that they included Native Hawaiian and Pacific Islander among those communities that need to be also focused on with respect to vaccine allocation. But unfortunately, Asian Americans were left out of that. A reference of other communities were noted instead. Next, please. These examples are a reflection of a long history of stereotype and biases that often work against Asian Americans. And we know that the end result is that funding for health-related research, for programs and interventions for Asian Americans is sparse. We also know that federal initiatives that prioritize data disaggregation and advancing health disparities research overall is very limited to for Asian Americans, as well as Native Hawaiian and Pacific Islander communities. 0.17% of the overall NIH budget was allocated to both of these populations. This has resulted in a severe lack of Asian American data and research. It impedes health planning, the development of evidence-based healthcare strategies and practices, And as I mentioned earlier, without data and research, Asian Americans historically don't receive access to important federal services, programs, and resources. And this bears out locally. Asian Americans earn nearly 15% of the city's population in New York City, yet received 1.4% of the city's social service contracts. Thus, the impact of the lack of data, equity, and research funding is that Asian Americans are invisible in many ways and systematically excluded in health disparities discussions. So what are the ways to address that in terms of thinking about how to improve research, how to improve the evidence with respect to targeting and supporting Asian Americans? Next, please. Our center has helped in many ways to address some of the gaps, but we know that we are not alone. And we are working in concert with a number of community partners nationally to think through how do we help to change and affect policy to really support more centers across the country to reach and engage the diversity of Asian American subgroups. So let me talk a little bit about some of the work that our center, the NYU Center for the Study of Asian American Health, which I'll fondly refer to as CISA, some of the work that we have been doing for the last 19 years. Next, please. I co-lead the NYU Center for the Study of Asian American Health with Dr. Simona Kwan. And this center was established in 2003 through a Center of Excellence Award. At the time, it was the National Center for Minority Health and Health Disparities. We are now, as I mentioned, now going into our 19th year as a Center of Excellence. In 2007, we transitioned our work from being focused in New York City to being a national center, given the great need to build collaboration and solidarity among Asian American researchers and community partners. At its height, there were probably about 76 centers that were supported through NIMHD. And now currently there are about, I would say, 12 centers that are funded. And we still remain the only center focused on the health and health disparities of Asian American communities. Next, please. We have developed an integrated framework to guide our work, and we operate at multiple levels of influence, relying on this wonderful framework that actually the NIMHD developed in terms of looking at health disparities and looking at the multiple domains and influences on health and health disparities. We pay careful attention to social determinants of health and the contextual factors that lead to health inequities. We also work to apply multi-sector approaches to our coalition building, working in concert with community partners using a CBPR, a community-based participatory research approach, to strengthen community leadership and also build very strong community clinical linkages. We're huge advocates of the community health worker model, not only with respect to delivering health interventions, but also as part of the healthcare team and a vital strategy to addressing social determinants of health. And we have a strong commitment of building the pipeline in the next generation of healthcare providers and researchers. Next, please. So this busy slide here illustrates our growth over time. Initially, we began in 2003 with a focus on 3 scientific tracks: cancer, cardiovascular disease and diabetes, and mental health. And we have deepened our research portfolio for these tracks through NIH and CDC funding. In 2017, with our current renewal, we established 2 new tracks, one on healthy aging and Alzheimer's disease, and the second one on gender equity. And just to illustrate the significance of having a Center of Excellence Award, when we established the healthy aging and Alzheimer's disease track, we were able to mobilize academic and community partners to secure 3 NIA Alzheimer's disease supplements to our U54 grant in 3 consecutive years. And as a consequence of that work, we were able to solidify our collaborations with geriatric medicine and the Alzheimer's Disease Center at our institution, as well as with national partners like the AARP and the City Department for Aging. And as a result of those efforts, we also then received, as I mentioned earlier, an NIA R24 infrastructure grant, engagement and longevity in medicine to strengthen community engagement and recruitment of diverse older adult populations who are underrepresented in research. An academic leadership award to build a research training program on Alzheimer's disease and aging health disparities. We're now part of one of 3 CDC-funded Bullitt Centers of Excellence focused on the prevention of Alzheimer's disease disparities. And as I mentioned earlier, Alzheimer's disease has become a growing and tremendous disparity for Asian American communities. And so being able to utilize the infrastructure of the Center of Excellence to grow the research where we know there's a lack of research has been really instrumental. Next, please. This figure here depicts our trajectory of what the Center of Excellence infrastructure has enabled us to do. So as I mentioned, since our inception in 2003, and with each consecutive cycle, we've really increased new grant awards. And these resources have bolstered each of our scientific tracks. What is not reflected here are the institutional awards to NYU, for example, of which our Center of Excellence is a critical part of, and the Foundation for Health Disparities and Community Engaged Research. And these include the NCATS-funded Clinical Translational Science Institute, our NCI designated Comprehensive Cancer Center, an NCI Cancer Disparities Score Grant, an HLBI Decipher Grant, an NIHS Environmental Health Centers, an NIA R24 Aging and Alzheimer's Disease Infrastructure Grant, the CDC Prevention Research Center, a CDC Cancer Prevention and Control Research Network Center, a Bullitt Center of Excellence on Alzheimer's disease prevention, and just recently, an NIH Community Engagement to End COVID-19 Disparities, a SEAL Award. Next, please. I'm going to share a little of my center's current cycle in terms of some of the research that we're doing now. Next. We utilize a cross-cutting framework that harmonizes 2 research projects funded through the NIMHD Center of Excellence Award, and this builds off of the NIMHD's Health Disparities Research Framework. Both projects employ a participatory CBPR approach and really think through multi-sector partnerships. In that approach, we also apply implementation science frameworks like RE-AIM and the Consolidated Framework for Implementation Research to help provide a practical guide to systematically assess barriers and facilitators, and to help support research translation and scalability across different settings and across different subgroups. We also are working in both projects to harness community assets by fostering community clinical linkages, and I'll talk about that in a little bit. And namely, we're capitalizing on the important role of community health workers and the opportunity of EHR, electronic health record-based initiatives to really think through sustainable intervention strategies. And finally, both research projects are committed to research and action in the form of policy and practice change. Next. So one research project is led by Dr. Nadia Islam, and it focuses on diabetes management. It is testing a community clinical linkage model, working with small primary care practices. In New York City, small primary care practices are the primary provider of care for minority and immigrant populations. And they also provide 40% of primary care in the city. Oftentimes, these small primary care practices, in the case of the South Asian population, are trusted in their communities. They have bicultural, bilingual staff. Their patient populations have high chronic comorbid health disparities. And so they're limited with respect to staffing support, as well as access to EHR-based support to help improve provider adherence to recommended guidelines. Next, please. We are in the midst of our study, and so the findings have not been, will not be released yet, but we have made great progress in terms of its activities and impact. And we've outlined some of the activities that we've done to really engage community participants and community members in a number of events, as well as our impact and our reach. We've also been able to secure 8 additional grants to help leverage what we do and really think about scalability of those efforts to other communities and to other settings. Next. And I just want to touch that in light of the last 15 months, we had to pivot really quickly to be able to do our intervention, to do our research in the context of COVID-19. And so we pivoted quickly to develop our health education sessions and data collection, which were initially in person, to remote training our community health workers and helping them to support that, to be able to do that virtual setup and to also be able to support their participants successfully. And I didn't mention earlier, community health workers, we tend to hire from the community, and we tend to hire individuals based on their long history of community organizing or their work in their communities, and less on having a higher education degree. And so there was some effort to also support digital literacy, to be able to train our community health workers to work in Zoom, in WebEx, and to be able to continue to do the intervention sessions with high fidelity. We also had to pivot in terms of moving away, as I mentioned, from in-person one-on-one sessions for physical activity to doing digital videos that supplemented some of the curriculum content. And so some of our exercise demonstrations, our cooking demonstrations, talking about recommended guidelines for diabetes management were all, we pivot quickly to doing more video access, being able to support that access through YouTube so that our participants would, really could just simplify their ability to engage and participate in the study. Next. And so the other study is focused on stomach cancer prevention among Chinese Americans. And that is also a randomized controlled trial to assess the efficacy, adoption, and impact of an integrated community health worker and EHR-based intervention strategy to improve adherence to H. pylori treatment for communities at risk for stomach cancer disparities, and particularly for Chinese American communities where there was a high percentage of individuals with high rates of limited English proficiency. We worked with the Health and Hospitals Corporation and with the Family Health Centers, which is a federally qualified health network that serves a diverse population, including a high proportion of limited English proficient Chinese American patients. And through that effort, we were able to create EHR-based tools to help busy physicians at the Health and Hospitals Corporation and at the Family Health Centers integrated into the EHR, into the EPIC system, which is actually a system that many healthcare providers are using across the country. And so there's opportunities to think about replication and scalability of that work in other settings for other communities. And we developed patient education materials in English, Chinese, and Spanish. So that was very easy for providers to be able to link up and have access to those materials. Currently, the study is focused on the Chinese American population, but we hope that eventually we'll be able to test this model for Spanish-speaking populations who are at high risk for stomach cancer disparities. And so I think one of the most significant things about this project was its integration into the largest public health care system in the US, and to support providers to be able to do more targeted and tailored intervention strategies, and then also support patients by linking them to community health workers who would then follow them up with appropriate education to support adherence and to support healthy lifestyles change to also further reduce stomach cancer disparities. Next. Like the other project, we're still in the midst of study implementation, but have made great progress in terms of our activities and impact. And we've also been able to leverage that work to secure additional grant funding to do more of what we're doing with respect to CHW and EHR-based intervention strategies. Next. We've also had to transition our work, and we've transitioned it very successfully to be able to deliver our intervention in the context of COVID. And this has really, and those efforts in terms of adapting our research and our ability to pivot quickly with respect to providing digital literacy trainings to community participants and working with our community organizations also helped to set the stage for us to engage community members and community partners around COVID-19 vaccination. Next, please. In terms of one of our aims, we have a strong focus on supporting the next generation of health disparities researchers. So we have this terrific investigator development core that's co-led by Drs. Lorna Thorpe and Thaddeus Tarpey. We have two signature programs within that investigator development core. We have a health disparities research training program that was developed in 2003 in our first cycle. And in this current cycle, we've had work with 82 trainees through the health disparities research training program and about 411 since our inception. In terms of our pilot project program, we provide pilot project awards to early stage investigators, primarily junior faculty and postdoctoral fellows who have not received their first investigator-initiated award, their first R01. And so we work with them with respect to developing pilot projects, to securing the preliminary data that's needed for effective applications for a K award, a career development award, as well as for independent investigator awards, the R level grants. In terms of the impact, this is based on just 3 cohorts of pilot project grantees. We've been able to secure 5 K awards, 4 R awards, and 2 U54 supplements to really extend the work that they're doing, as well as 10 other grants through either foundation or other internal funding to further extend their pilot project research. They've been very active with respect to publishing. One of the things that we do is to provide very intense workshops, supporting them in terms of their writing and their development. And our awardees have published over 130 publications. And then in the last few cohorts have had 16 publications that are directly related to their pilot project. Next. In terms of community engagement and dissemination, this is an area that I'm very proud of. We partner with the Asian Pacific Islander American Health Forum. They are the oldest and largest policy and advocacy organization serving Asian Americans and Native Hawaiian Pacific Islander communities. And they work with local coalitions across the country and across the Pacific Basin. And so they've been a key partner on a number of initiatives since 2007, and really been a critical part of what we've been doing during this current cycle with respect to data dissemination and with respect to policy. We also, our Community Engagement Dissemination Core facilitates our National Advisory Committee and our Scientific Committee, which is comprised of members from community organizations, as well as academic institutions and foundations from across the country. And they also represent not only the Asian American population, but they also represent communities reflected in the Native Hawaiian and Pacific Islander communities, because we're recognizing, as I mentioned earlier, that for Asian Americans overall and for other racial and ethnic minority communities, we often need to work together to inform policy change and to really think through what are the best strategies to support health equity. Next, please. So we're working in concert with our National Advisory Committee, our Scientific Committee, and the Asian Pacific Islander American Health Forum. We are conducting a series of community health resource and needs assessments. CISA has traditionally done a needs assessment in every cycle of our funding to inform our strategic priorities, to make sure that what we do is relevant to community needs and priorities, and that we address any emerging issues in the next cycle of funding. In this current cycle, in partnership with our National Advisory and Scientific Committee, we've been able to think through what are the ways that we can do regional community health resource and needs assessments. And so we're working with community organizations so in Atlanta, Georgia, Phoenix, Arizona, and Salt Lake City, Utah. And we'll be able to take that data and compare it to data that we have in New York City. And through this intensive process, we've been able to work with our community coalitions in these areas and in New York to co-develop, co-create a survey and to think through the survey implementation plans, to develop a suite of trainings to strengthen community capacity, to conduct community-based data collection, and also to create a data sharing and equity agreement with all partners that feels good to our community partners. They are invested in owning this data too, and being able to disseminate that data in ways that have practical benefit to their communities. Next, please. We're actively engaging in a multi-pronged effort to disseminate our work through conferences, social media, digital stories, YouTube, and also working on our second textbook on Asian American communities and health, which will be published hopefully by the end of this year, or if not early next year. Next, please. And so building on our work with the Asian Pacific Islander American Health Forum, as well as work that was funded through the National Library of Medicine, we are developing a searchable, curated website that includes research tools, resources, and data linking to external as well as CISA developed content for Asian Americans and Native Hawaiian and Pacific Islander communities. Next, please. We've also learned that communities want information and data that has practical benefit to their communities and organizations. They want information that's tangible and information that would inform what they need to do to serve their communities better. They don't want it necessarily in peer-reviewed journal publications. They want it in the form of monographs, policy briefs, graphics that it's easy to understand, that can support actionable work in ways that, and they also want information that is accessible in multiple languages and multiple formats, as well as information that is immediately accessed and publicly available. And so, led by my colleague Stella Yi, the Health Atlas is comprised of secondary data analyses that showcases health-related prevalence estimates to visualize existing data, as well as data gaps for Asian American and Native Hawaiian Pacific Islander communities. The Health Atlas focuses on Asian subgroups as well as the Native Hawaiian Pacific Islander populations, and it utilizes data across 2 national, 5 state level, and 3 city level data sets that capture health behaviors, lifestyle behaviors, and risk factors. I just want to underscore, though, that while this is a helpful tool in terms of providing a sense of disease prevalence and risk and protective factors, we still need longitudinal data. We need longitudinal data to really understand risk and protective factors and their relationship, to really understand causal factors and the impact of social determinants of racism and discrimination on health across diverse Asian American communities, as well as for Native Hawaiian and Pacific Islander groups. Next. We've also partnered with the Robert Wood Johnson Foundation funded City Health Dashboard, which is led by our colleagues, Drs. Mark Ravitch and Lorna Thorpe. The City Health Dashboard is an interactive tool that displays 35 different health indicators in 750 largest cities in the US. And I just want to talk a little bit about the process of how the City Health Dashboard was created. Mark and Lorna worked very closely with local municipalities, with mayors and public health agencies to think about what data would be relevant to inform policy and programming at the local level. And using that information, they were able then to create a City Health Dashboard that could be utilized across these 756 cities. In collaboration with them, and through one of the pilot project awards that we were able to provide, we were able to add Asian and Latinx subgroups to the dashboard to support visualization of those different subgroups across those 750 cities. And these are just sample maps for Houston and Hawaii. I urge you to check out the City Health Dashboard if you haven't already. Next, please. In an effort to address the data deficits that were recognized at the national level, since June of 2020, one of the activities that we've been engaged with the Asian Pacific Islander American Health Forum is a CDC-funded Forging Partnerships project. This is a project in partnership with the Health Forum, as well as 6 community coalitions. Next, please. Our project is driven by this a set of coordinated activities around data and the need for data to understand the impact of COVID-19 on Asian Americans, Native Hawaiian, and Pacific Islander communities. So it begins with direct community input, which we receive from our community partners across the country, from community health workers, and from community members themselves. Next. This input is anchored by 8 community-based primary data collection that uses the same questions across different surveys. Next. It also utilizes secondary data analyses from 6 local, state, and national data resources, as well as coordination with 15 additional data collection and collaborative efforts. Next. So these activities equate to 360 organizations and 65 individuals across the country working together. Next. We've also actively tracked all of the published scientific literature, social media, and news on COVID-19 and Asian Americans, Native Hawaiian, and Pacific Islander communities. And these findings are being shared directly with the CDC, as well as with NIH and other community partner organizations. Next. And through multiple resources, we've been able to piece together information about how different Asian subgroups are experiencing the COVID-19 pandemic and have compiled them into a succinct resource that we can share. This resource helps to appreciate that despite some of the commonalities across Asian subgroups in their experience of this pandemic, for example, next. For example, facing challenges due to limited English proficiency, fears around public charge, it also highlights differences across subgroups. Next. So being able to capture data disaggregated across the subgroups, but these are for the 5 largest subgroups. We really need to do more with respect to understanding the smaller emerging communities across the country, and also to examine regional differences for those communities. Next, please. So our work at CISA with respect to COVID has evolved quickly, and it spans community, data, clinical, and policy arenas. Next. As I mentioned earlier, we have pivoted really quickly to developing community-facing in-language content in response to our partners' needs. The pandemic, New York City was at the height of the pandemic in March and April and May. It was a very stressful time for the city, but also very stressful for limited English proficient communities and for low-income immigrant communities, where sheltering in place was challenging on a number of levels. Many of them were working in low-wage frontline positions, had very limited options, and often, commuted in public transportation. And then, as I mentioned before, there was also fears related to xenophobia and stigma around COVID-19 in Asian American communities. And so during that time, at the height of the pandemic, we had to really pivot quickly to working with our community partners to developing community-facing in-language materials in the form of brochures and pamphlets and palm cards, and also in webinars and YouTube sessions and infographics to be able to share information about COVID-19, about communication and really reducing that risk, and then very recently around COVID-19 vaccine. Next, please. CISA has also been very active in raising awareness, providing testimony on the Asian American experience with the pandemic. We have spoken at the White House COVID-19 Health Equity Task Force with the city and state health departments, to a number of state and federal government officials, have provided testimony which have been included in reports that have been presented to Congress around the impact of COVID-19 on Asian American communities. Next. And I just want to touch on the role of the community health worker during this time. We are long advocates of this model, given their vital role in bridging access to care and imparting culturally and linguistically relevant information to improve screening and treatment adherence. But they are also a powerful in their ability to address social determinants of health, which was made even more evident during COVID, as they supported navigation to healthcare resources, health insurance access for newly unemployed individuals, financial assistance, food access, medication deliveries, and in-language information on COVID and on available vaccines. Next. Despite high limited English proficiency barriers and fears due to public charge and the stigma attached to the coronavirus, particularly towards Asian Americans, CISA and our partners have worked together to successfully engage Asian American communities around COVID-19, around vaccine hesitancy, around vaccine access, helping to navigate them when we can, particularly for communities where with low digital literacy, or it's just much more challenging to be able to schedule appointments. We've been able to facilitate that access. And the New York Times recently, in early May, highlighted this phenomenon in New York City of the fact that Asian Americans were among the most vaccinated group in New York City. I do want to note that this is not the case across the country in many areas, and even within New York City neighborhoods. We still are working to address pockets where there are still high concerns around vaccine hesitancy. But we do know that working with our trusted community partners and with community health workers, that it goes a long way in terms of addressing vaccine hesitancy and concerns, as well as a long way in terms of facilitating access to vaccines. Next. We are fortunate to lead one of 21 regional SEAL Awards, and this is in partnership with a number of academic institutions like Mount Sinai and Institute for Family Health, as well as colleagues at Columbia University and Einstein academic centers that have traditionally served minority and health disparity communities, and who have a network of community partners who are boots on the ground and who can really engage hard to reach underserved communities around vaccine hesitancy, and also to be able to understand some of those issues. The SEAL Award has been a catalyst for our community partners. We have worked with them to coordinate efforts with respect to communication and dissemination. We're creating a centralized repository of culturally and linguistically relevant materials. And where there is a lack of materials that's in language, we're working to develop that with our partners and to be able to deliver those the education and information through our community health workers or community navigators that are based at our community organization. We've also been able to work with our community-based organizations to optimize their capacity and leadership. We have been able to secure additional funding from the CDC Foundation, as well as additional supplements and other collaborations with Radix Up to really extend that impact and to provide the resources that communities need around understanding the impact of COVID-19 and really dispelling medical mistrust and dispelling some of the myths around the vaccine. Next. And I just want to highlight, we have had measurable impact in terms of publications, trainings, and grants. Traditional metrics that we would utilize in our grant renewal, but there's this immeasurable and qualitative impact of centers of excellence for advancing health and racial equity. And I'm just going to quickly go through that because I think it's really important to underscore. Next, in 2002, when we responded to the RFA to develop a comprehensive center, health disparity communities that were eligible for this award included African American, Latino, American Indians, and medically underserved communities. Asian Americans were not included in that eligibility. To make the case, we had to demonstrate that we were a medically underserved community, and we had to provide data documenting the access to care issues and the various health and social disparities experienced by our communities in New York City. Immediately after receiving the award that formally established CISA, Asian Americans were recognized locally and nationally as a health disparity population. This was a milestone, but it's still an uphill battle for us with respect to highlighting the significance of really focusing or supporting research on Asian Americans, given the stereotypes that I mentioned of the model minority or the perpetual foreigner. But despite that, the Center of Excellence infrastructure has been really a critical award in terms of mobilizing partners, multi-sector partners, community organizations to work with us locally and also with us nationally. It has also been able to support a deep bench of community engagement that has become a centralized platform for emerging issues. We were able to respond quickly to the COVID-19 pandemic to address the time-sensitive research and public issues that our communities were immediately confronted overnight because we had already developed that trust and rapport with many community organizations and utilizing participatory approaches and engaging them in a number of conversations. And also another important aspect of the Center of Excellence Awards is that we are now a national resource for data, dissemination, and policy. Next, please. Through the Center of Excellence, we are able to use that platform to advance dialogue with policymakers and community stakeholders around data disaggregation and inclusion. Next. We've been able to be involved in a number of initiatives and present those findings to various audiences, including policymakers. And one of the major findings from a needs assessment illustrated the high burden of mental health among Asian Americans and Native Hawaiian and Pacific Islander communities as a result of the COVID-19 pandemic. And as a consequence of that effort and that project, Representative Judy Chu then reintroduced the Stop Mental Health Stigma in Our Communities Act just recently on May 28th. Next, please. It has also been a platform to help improve disaggregated data collection and reporting for all racial and ethnic groups. We are partnering with the Health Forum to do this nationally, and within our own institution, we're changing data collection best practices at NYU Langone Health with our colleagues at the New York City Health and Hospitals Corporation. And our recommendations have been included in a report to Congress prepared by the Congressional Tri-Caucus and the National Urban League. Next. It has allowed us to pivot and to be able to, after many years of advocacy for disaggregated data collection, to be able to receive funding to support disaggregated data collection for Asian Americans, and now just recently expanding that data disaggregation to Black and Latinx subgroups for New York State. Next, please. The Center of Excellence Award has also helped to advance community-driven priorities and strengthen policy. These are just some of the examples from understanding and supporting and advancing the community health worker model, to addressing hepatitis B and liver cancer disparities, to promoting evidence and practice-based policy systems and environmental level changes, to doing community-driven research around environmental health harms that are made unintentionally, by city efforts. So, for example, erecting a detention center in the middle of Chinatown, and then also addressing the COVID-19 impact. Next, please. So I'm going to touch really quickly on recommendations to advance health equity. Next. First and foremost, is we need to continue to challenge persistent stereotypes that undergird and reinforce structural racism. We need to push back against those stereotypes and to, in order to allow and support more representation, more engagement of Asian Americans, of supporting research funding on Asian American health disparities on the health, and looking at data disaggregated. Next. Another area that we want to, that I want to recommend in terms of advancing health equity is to decenter whiteness in the sense of decentering it from being the evidence base. When we're working with communities with substantial health disparities, and most of those health disparities are impacted by social and structural determinants of health, it doesn't make sense to center the evidence or center the gold standard on a population that's not reflected in those communities. When we utilize evidence-based programs from studies that are predominantly have a white population in their study population, it doesn't often translate well for minority and health disparity communities without significant modifications. We need to think about centering the development of effective strategies on racial and ethnic minority populations and on those communities experiencing those disparities. We also need to normalize the role of culture, of intersectional factors that impact healthcare decisions, that impact social norms and values. And we also need to think, revisit, and reframe what is labeled a challenge or a deficit, a cultural stigma, or a passive trait, and move away the negative framing. Next. We also need to rethink how we are providing healthcare, particularly when we're thinking about improving health and reducing health disparities among minority immigrant populations. We need to think about the inclusion of others who may be able to engage and really address some of the other factors that impact health promotion, that impact treatment adherence, and that impact disease prevention. And that would include integrating community health workers as part of the healthcare team, particularly in situations where we're working in low-income areas. We also need to think about incorporating social workers, given that many of the communities that we know who are experiencing health disparities, physical health disparities, are also experiencing high level of mental health needs and also stress. And we also need to think about how do we build human and social capital by hiring from within the communities themselves. Next. Nutrition is actually a great example of thinking about how do we center prevention and intervention based on the communities that we want to target or serve, really empowering communities to retain their cultural and social identity, centering nutrition and food choice in ways that are meaningful and potentially much more sustainable. Next. We also want to challenge the notion of what is good data and think of the power of thick data, of thinking about mixed method approaches, of understanding how we utilize qualitative data. The quantitative data still remains the gold standard, and we still need good quantitative and epidemiological data. But often for communities that experience high level of health disparities or who have limited English proficiency, their experience is not captured well in these surveys. We need to really understand the social cultural context. So thick and insightful data and data that is shared through digital stories or through storytelling provide really a powerful way to incorporate and integrate community voices when we're doing research. Next, please. We also want to improve disaggregated data collection and reporting for all racial and ethnic groups. Next. And finally, this is my summary of recommendations because I realize I am running soon out of time, but first and foremost, to really dismantle the roots of structural racism, dispel myths and stereotypes, to think about centering research approaches and health and healthcare strategies on racial and ethnic minority populations, to support data equity, to support more longitudinal cohort studies, to examine biosocial and environmental mechanisms for cancer diabetes and cardiovascular disease, as well as emerging issues such as Alzheimer's disease, and also to continue to utilize genuine community and patient engagement strategies. And finally, which I didn't get a chance to touch on, we need to foster workforce development and diversity in health disparities research and in healthcare. Next. Thank you.
Thank you so much, Chau. We have just a few minutes for questions as you went over a very comprehensive review of the field. And I just want to ask you one that we could follow up at some future point. The issue of the model minority is clear. It's wrong. I think it's a myth. I appreciate your tracing the history of it, rooted in anti-Blackness. I think that will help us get a better handle on it for those who had not previously been familiar with it. And in reality, the poor people and people who are disadvantaged exist in all populations, right? I mean, white Americans have the largest number, not proportion, but number of poor people in the country. But I think the rooting of the population statistics, so if you look at the national statistics for Asian Americans, granted with the heterogeneity of the group, and I'm leaving Native Hawaiian Pacific Islanders aside because they are generally tracked differently, and we don't have good, estimates of life expectancy, et cetera. But for most things, Asians do better than others, and like Latinos, and frequently, we have the longest life expectancy of the three groups that are measured, and we've called that the paradox, and people are still grappling with why that is. Some think it's going to go away with a time of acculturation and time here. Although by now about 70% of Latinos in this country were born in the United States as opposed to being immigrants, which Asians are eventually going to be there maybe, but they're at another stage. So I think it'd probably be good to root it in that context as well. So let me turn to Gina. Do you have questions for me? For Chau, I'm sorry, to answer.
Yes, it's in the chat box.
Can you read that, please? I can't find it.
Sure. This question is, I was wondering what advice you have for a postbac looking to get more involved in research in Asian American populations.
There's a number of researchers that you can certainly reach out to. You should certainly reach out to our center. There are a number of opportunities. I don't even know where to begin with that, but please feel free to reach out to me in terms of some of the research. I would imagine, are you a postbac within NIMHD or within?
Yes, this is an NIMHD postbac.
I would suggest that you reach out to myself, or also there's a number of grantees who are working within NIMHD who are doing work around Asian American health, and we could, depending on your interest, we could connect you.
Okay, I see another question came up. So what are the missing opportunities in addressing Asian American and Native Hawaiian Pacific Islander health disparities during the COVID-19 pandemic?
The missing opportunities? That's a good question. We recently, my colleagues Stella Yee and others recently released this report. Published in a health affairs blog about what we do know and what we don't know. And we know a little bit more, certainly on the larger Asian subgroups, but there's a lot we don't know on the smaller emerging groups. And so one of the things that we want to do is more targeted work, data collection, and working with our community organizations on understanding that. We also recognize that there are regional differences too. So even though there are higher vaccination rates for Asian American communities in New York City, for example, in rural areas where there are emerging Asian American communities, the vaccination rates are low from our understanding. And so thinking through how best to engage those individuals, we know there's issues related to fears around public charge, around immigrant status, about taking time off, and misinformation about the vaccine has also makes it very difficult And so one of the things that I would again urge more disaggregated data collection and reaching out to the smaller emerging populations. I mentioned earlier that, for example, the Bhutanese community, and also some within the South Asian community, the Bangladeshi community, have higher, barriers with respect to access in many ways. So really understanding those barriers and facilitators.
Thank you. Let me ask you a more sort of complicated, sensitive question. You at the beginning you mentioned the BMI 23 or issue of screening for diabetes, or thinking about diabetes risk. I guess that's the context. Which in the past, I particularly in different settings, our council. One of our council members presented on this on one of her talks. Has been a major effort to make people aware of it. As you may be aware, there's been in the past year probably a tremendous pushback on creating any kind of race-based clinical measures. Most notably, the estimated GFR for kidney function that had been in most laboratories that adjusted it and said for African Americans is this, for non-blacks, for blacks is this, for non-blacks is that. Others, including pulmonary function tests or bone density measures, had been adopted in clinical practice. What is the perspective of Asian American researchers now on that issue with the BMI 23?
I think we would recommend that we use the lower BMI cutoffs, given that there is a high diabetes risk at lower levels. I mentioned earlier, many Asian Americans themselves believe they're also a mono-minority, that they're also, that they're fit, or, because they might not fit certain BMI guidelines, they're not at risk. And so really ensuring that we can, identify those individuals early on so they don't get to the point where they have diabetes or have uncontrolled diabetes is really key. So I would think for our group of researchers that we would recommend utilizing the lower BMI cutoffs to really to make sure that we get at those individuals. We have in both the Filipino and South Asian communities, for example, they have high rates of diabetes and also hypertension, and they are often co-occurring. And so really, identifying individuals early on to reduce complications associated with that.
All right, no, I don't disagree with that at all. I'm just saying that there is this sort of line of thinking that this inherently is racist, and coming at it from that perspective, which I haven't gotten my full head around that whole discussion, but it clearly is a very active one in the clinical context, and perhaps that's more on the basis of what have been adjusted for blacks compared to whites. But so be on the lookout for that. I think it is something that it'll be good for everyone to weigh in on. So I'm going to close our director's seminar now. I want to express my appreciation for Chau for a very comprehensive and thorough review of a number of issues related to not just Asian American health, and also your extensive work in this space across the different groups. And I really appreciated early on as you presented the heterogeneity of the population in the categories that you did. I think that's a really step in the right direction of how we think about this group. So thank you again very much, and hope everyone enjoys the rest of your afternoon.
Thank you.
Your next Zoom meeting. Thank you.
Take care. Bye.
Bye-bye.